it's my pleasure to introduce our first speaker. Jeff Huffman is Associate Professor of Psychiatry, I think sometime in the next year, soon to be full Professor of Psychiatry. He's Associate Chief of our department and is in charge of our clinical operation. He also is in charge of what we call behavioral health integration, which is how psychiatry increasingly becomes part of general medical care. So Jeff is going to talk to you today about the relationship between depression and medical illness. So welcome, Jeff Huffman.
Good morning, everyone. I'm so honored to be able to talk to you today about the connections between depression and medical illness, the importance of those connections, and the real hope we have for improving people's not just mental health, but physical health as a result of treating their depression. So first, depression, serious clinical depression is common. Every year, 700,000 Americans suffer a heart attack. 1.8 million Americans are newly diagnosed with cancer. And every year, 16.2 million adults suffer a major depressive episode. And it's not just that depression is common, but it's also, as you may well know, incredibly debilitating, incredibly disabling. The World Health Organization has now declared that by next year, the world's second most debilitating illness of any kind across the world is major depression, behind only heart disease. And depression has direct effects on mortality, on people's survival. Suicide is now completed in 45,000 Americans every single year, and that number continues to grow. Suicide's now the 10th leading cause of death in the United States and the second leading cause of death among young people 15 to 44. And not surprisingly, depression is the condition most associated with suicide. But importantly, I think the most important effect of depression is actually on our physical health. Depression is very common in people who have acute medical conditions, anything from a stroke to a heart attack, a new diagnosis of cancer, Parkinson's disease. About 15 to 20% of people with those conditions suffer chronic, clinical, serious depression. And this is also true for people who have more chronic medical conditions. So compared to people who are screened in primary care in the general population, people with chronic medical conditions, heart disease, lung disease, kidney disease, have much higher rates of depression. Again, about 15 to 20%, almost 1 in 5 people have serious clinical depression. And the more serious medical conditions you have, the more likely you are to have a serious clinical depression. And you can imagine how having a medical illness and having a depression can really interplay and complicate one another. So that begs the question, which comes first, depression or a medical problem? Well, it's certainly true that having a medical illness can exacerbate or precipitate depression in people who are prone to it. The psychological effects of having a medical illness can be profound. The symptoms of medical illness, whether it's low energy or pain or fatigue, sleep problems, can certainly all affect people's ability to sort of maintain their mood and avoid depression. But at the same time, and really importantly, the other half is true as well. Depression can precipitate and predict the onset of medical illness. The neurobiological condition of depression can actually precede medical illness in a way that's really important for people's recovery of their whole body. And I'm going to talk about that a little bit here. This line that you see is kind of the line of health, from people starting as medically healthy people, then developing a chronic medical condition, maybe like diabetes, having an acute medical event like a heart attack or a stroke, and then surviving or not. And I'll talk a little bit about how depression is associated with progression of illness, medical illness, across each of those hubs. So first, depression is associated with the new onset of medical illness in people who are previously healthy. There was a famous study years ago called the Johns Hopkins Precursor Study. This was a study done in medical students from the 1950s, followed for 40 years. And they found that the young doctors who were depressed in their 20s or 30s were more likely to get medical illness of any kind compared to their colleagues who were not depressed in their 20s or 30s. Independent of their ethnicity, independent of their gender, independent of family history, depression appeared to predict getting medically sick. And this has now been seen in men and women, different socioeconomic strata. For example, if you're depressed in your 20s or 30s, you're about 60% more likely to develop heart disease than if you weren't, especially if you don't get treatment. Depression is also associated with the progression of medical illness. For example, people who are diagnosed with a chronic condition who are depressed are more likely to have that condition continue to get worse. So for example, one study found that people who are diagnosed with heart disease, who were depressed at the time of diagnosis, were about 60% more likely to have a heart attack in the next 2 years compared to people who weren't depressed. And finally, and most strikingly, depression is associated with mortality, with death in people who have acute medical illness. For example, if you're depressed after you have a heart attack, you're twice as likely to be dead in a year than if you weren't depressed. And again, these associations between depression and medical illness are independent of how serious your medical condition is, what kind of family history you have, your age, your ethnicity, and so forth. And as this data has been accruing, the American Heart Association, as one group, has really started to identify the importance of depression. Depression is now considered a risk factor, just like you think of smoking or high blood pressure or diabetes as risk factors for heart disease. The American Heart Association has now declared depression as a risk factor for poor prognosis after a heart attack, really underscoring how the medical community is starting to understand how depression can be a toxic syndrome for patients who have medical illness. And it's not just about heart disease, and it's not just in the US. Now there have been studies of more than 2 million people, all of which have found that if you're depressed at any given time point, that predicts a greater risk of dying by about 60% over just about any time span you can think of, independent of other factors. Depression is an independent predictor of adverse medical events. So how might this be the case? How does depression actually make a person more medically sick? Well, there's probably two different groups of mechanisms, two ways in which this happens. First, there are biological effects of depression that aren't so good for you. So depression is an inflammatory condition. Depression actually raises levels of something we call cytokines, these inflammatory molecules that go throughout your body. And depression increases systemic inflammation. Inflammation in your vessels, in your organs, can lead to more medical problems. And some people think that depression and inflammation is really the pathway by which medical problems are more common in depressed people. Depression also affects these cells called platelets, which really cause blood clots and stickiness. And if you have sticky, clotting blood cells in your brain, in your heart, and other places, that can really predispose you to having episodes like stroke or a heart attack or those kinds of major medical events. Depression also really boosts people's fight or flight nervous system, puts people kind of in a constant state of fight or flight. And this constant state of fight or flight in depression can lead to sort of a wearing down in a lot of ways of people's sort of medical stability, resilience, and health. And so people think that it may be the case that depression's effect is really biological, and its effect on medical survival and conditions and recovery is really very biological. But in my opinion, the biggest effect of depression is actually on behavior. People who experience depression have problems with motivation, with energy, with concentration, with sleep. And people who are depressed are less likely able to make really important health behavior change. They're less likely to follow a healthy diet, to get more active, to take medications, to make use of social support that's so critical to survival, to get good sleep. And all of these factors, healthy diet, healthy exercise, good sleep, are all associated with doing well from a medical standpoint. Okay, so this talk has been a total bummer so far, right? Depression is common, it's terrible, it's there all the time, it's associated with death. Oh my, what are we gonna do? That's the truth, but there's a lot of hope. A lot of our existing treatments that we have already are good, not just for people's mind, but they're good for people's body. And there are new treatments coming down the pipeline that might even further tip the balance. So as one example, SSRIs, antidepressants that we all have heard about, Zoloft, Prozac, Paxil, Lexapro, Celexa. These medications actually appear not just to have good effects on people's mood, but actually on their medical health. There have been studies done in the US and abroad finding that prescription and taking these medications is associated with lower rates of heart attacks and lower rates of death. And there was a really interesting study done of depression and heart disease. It was called the ENRICH trial. It was actually a study of therapy. And so half the people got therapy for their depression after a heart attack. Half the people just got regular treatment as usual. And what happened was that as this trial went on, some of the people in both groups also ended up getting prescribed SSRIs, these antidepressant medicines. And so they found that the therapy helped people's depression. But what they also found was when they analyzed the data differently and just took everybody who got an SSRI, whichever group you were in, and everybody who didn't get an SSRI, they found that people who took these antidepressants, no matter whether they got the therapy or not, had about a 50% lower risk of having a heart attack, another heart attack over the next 5 years. These medicines seem to be doing something good for people's hearts. And that led to the question, how is this happening? Why are antidepressants, why are these medicines particularly effective in helping people's medical health? And it turns out they probably have what we call pleiotropic or polymorphic effects. These medicines are good for people's depression and anxiety, but they also appear to lower inflammation. They have benefits on these extra sticky cells, these platelets, to calm them down. They lower people's fight or flight autonomic nervous system. And so these medications, above and beyond the effects that they have on people's mood, may have beneficial effects on health. Exercise, physical activity, turns out to be a good antidepressant and of course is really good for your health. So it turns out that aerobic exercise, anything just like brisk walking, moderate activity, is almost as good an antidepressant as an antidepressant, and is almost as good as cognitive therapy at treating depression. And it's also, of course, incredibly effective in reducing medical illness and reducing mortality. This graph here, I kind of want you to see this because as a physical activity researcher, I often get asked, how much activity should I be doing? And this graph here, you can see the graph is basically showing rates of mortality, and on the right, there's more exercise. So you can see the more exercising you do, the lower your mortality risk, the lower your risk of dying. And here at the second bullet here, you can see that as you get over here, I'm going to see if I can do this here. I can't. That's all right. So the long story short is if you are doing a recommended amount of exercise, they recommend now a couple hours a week of moderate activity like brisk walking, you lower your risk of dying, of mortality by about 30%. That's great. But right next to it, if you're only doing half the amount you're supposed to be doing, you lower your risk of mortality by 20% compared to people who are not active at all. So I always tell people, do anything. Walk around the block, walk up some stairs, take a bike ride. Anything you do is lowering your risk of dying, of mortality. If we all, at the end of this seminar today, went and took a walk around the block, we would all be lowering our risk of dying by some small incremental amount. So a little bit of exercise, even a little bit, is not just good for your physical health. It can lower your risk of mortality, and is pretty good for your mood. There are newer treatments in the pipeline that help the biological effects of depression. There are these new treatments called anti-cytokine effects. They're very powerful anti-inflammatory medicines. They've been used for conditions like rheumatoid arthritis or lupus, inflammatory conditions. But when they studied them, they found something really interesting. They found that when they gave these medicines to people with these conditions, whether or not it helped their arthritis, it actually helped to reduce their depressive symptoms. These effects on inflammation that I was talking about before may be really important, and by lowering their inflammation, it may actually help their mood. And so we're starting to study whether these medicines are effective for depression, not in people who have inflammatory conditions, but in people who have just plain old depression that don't respond to regular treatments. New approaches also involve better programs of care to provide high-quality expert care for people to be able to receive care within their medical home. These collaborative care approaches really appear to allow people to get excellent medical care in a way that's different than they usually do. So most people get their depression care from their primary care doctor who may have interest or experience with treating depression or not. Or they get it from a psychiatrist who's an expert but may not coordinate at all with a primary care doc. These collaborative care programs actually embed a care manager in patients' primary care practices who's a depression expert. gets recommendations from a psychiatrist, the medicine gets prescribed, or the treatment gets prescribed by the PCP, and the patient gets expert care and great support all within their primary care doctor's office while still getting really expert and wonderful care. These programs have been effective and cost-effective. One study looking at older adults for a year found that rates of heart disease were lower in the usual care arm. Among people who are getting usual care, rates of heart disease were about 50%, and people getting this collaborative care were around 22%. Just from 1 year of this program, over the course of 10 years, it reduced people's risk of heart disease. We've also done it in our inpatient cardiac units. We've moved to help people with heart attacks by using the same model. We've reduced their depression. We've reduced risks of rehospitalization. People who are in our program with depression and heart disease actually have rates of rehospitalization that are half of people who are getting treatment as usual. And we are expanding our program to what are called blended collaborative care, where we actually have nurses who not only focus on depression in people who have depression and heart disease, but they help people set behavior goals, they help people monitor their blood pressure and blood sugar. And we've had wonderful effects in really complicated situations where people have heart failure and depression and need kind of hospital-to-home help from a care manager. And we've been able to provide that support to people and reduce their rates of rehospitalization. And it's been a really fun and interesting program to deliver. Last but not least, the best way to treat depression is to prevent it in the first place. So our colleagues at MGH in our Corrigan Heart Center are starting a cardiac prevention program that focuses not just on traditional risk factors, but also on really psychological well-being and its importance in people's recovery. Benson Henry Mind Body Institute, through our own psychiatry department, is focused very much on improving sort of stress reduction as a sort of vehicle to improve people's physical health. And our own team has developed something called the PEACE program, Positive Emotions After Cardiac Events. This is a program designed to promote physical activity among people who have had a heart attack. This is a really important issue because people who are not able to get active after they've had a heart attack are more likely to suffer another heart attack or to die in the next couple of years. But it's a really hard thing to do to get more physically active. And so what we do is we've taken a strengths-based approach. We've helped people to enhance their optimism about getting more active. We help people engage with their own gratitude about their health and their life. We have people pick personal strengths and use them in new ways. We have people think about the ways they've been successful in the past and how they can apply it to this problem. And we found that this approach to increase motivation and sense of self and self-efficacy is like rocket fuel to help people really make this important behavior change. And we just completed a trial and saw some big changes in people getting more physically active after a heart attack. So in sum, depression is common. It's pervasive. It's an independent risk factor for getting or dying from medical illness. And these connections are probably biological and behavioral, but our existing treatments like SSRIs, doing things like exercise, emerging treatments like these anti-cytokine medicines, and our prevention approaches that really focus on people's strengths, really focus on sort of giving people good wraparound care, all give us a lot of hope, all give me a lot of hope that these effects of depression on medical illness can be reversed and we can do a lot of good for a lot of patients. Thank you.
We'll take one question, but we will have a panel later, so we can take a lot of questions. So if we have one quick question, we'll take it now. Otherwise, we'll defer to the panel. Yes?
It seems to me that depression is a measurement of stress in an individual and how they deal with that stress. Now, the SSRIs and the exercise are both effective in reducing the depression or distress. Do you think that the SSRIs are a reduction of a flame to a boiling pot of water, whereas exercise is the release of that
Yeah, I mean, the other thing where I thought your question was going was also teaching people skills to manage stress. So there's a lot of different approaches to the syndrome we call depression. There's medications which seem to help neurobiologically, like these SSRIs, and they seem to help with, chemical neurotransmitters and brain neuron genesis and those kinds of things, and that's a really important approach. Exercise is sort of the flip side, as you suggest. It's a way to actually promote activity, activation, and actually has similar effects on brain neurons and those kinds of things, but is sort of the flip side of actually taking away a problem, is actually sort of adding resilience in a way. And then third, there are therapeutic approaches which help teach people skills about stress reduction and managing depression, and all of them are effective differently for different people. There is a lot of treatment matching that happens, but there's no one single approach that's probably best for all people, but there are lots of different approaches to this boiling pot of depression that may be effective.
Jeff, that was just brilliant. Thank you. That was terrific. And our next speaker.